So this is a patient I saw with Dr. Laura Cavini in Oak Hill, West Virginia. I'm presenting it on behalf of her. When I saw the patient, we were just talking more about like an acute problem, but then Dr. Cavini filled me in on this problem that was going on in the background. So to begin, the patient is a 37-year-old female with a past medical history of obesity, anxiety, and depression. She presented to Mount Laurel Medical Clinic on September 27, 2019, due to worsening anxiety and depression. At the time of the visit, she was taking amitriptyline 25 milligrams daily, and that was for depression and sleep, duloxetine 60 milligrams daily for anxiety and depression, and then lorazepam 1 milligram as needed for anxiety and panic. So at that time, she expressed desire to discontinue duloxetine because she felt like her anxiety problems were, her anxiety and depression had worsened while she was on it. So we had a discussion about medication options, and then the decision was made to switch to venlafaxine. And then the plan was also made to increase the amitriptyline to 50 milligrams at the same time. So in preparation to be on Prestique, the patient was weaned off of duloxetine. So the regimen for weaning, they decreased her dose to 30 milligrams daily for 2 weeks, and then followed by 30 milligrams every other day for 2 weeks. And then the weaning regimen didn't really go that smoothly. The patient experienced significant withdrawal symptoms, including insomnia, vomiting, nausea, and had a worsening of her anxiety, and that persisted for about 2 weeks. And then during that time, we learned that the patient's insurance wouldn't cover Prestique. We were also having trouble getting her in to see a psychiatrist. So as far as behavioral assessment goes, patient reports worsening sleep, feeling depressed and hopeless. She recently quit smoking, which was a large stressor on her. That was one of the tools she used for coping. And then as of November 11th, she had reached out to FMRS, which is a local counseling service down in Fayette County. And she had her first appointment with them a few days after that. So currently, her medications are amitriptyline 50 for depression and sleep, venlafaxine 3.75 milligrams for depression, lorazepam 1 milligrams for anxiety, and then failed medications include citalopram, fluoxetine, duloxetine, and venlafaxine was previously on her failed medications because she reported memory loss. But then when everything was going on with the duloxetine, she requested to have the venlafaxine started again. She doesn't have any history of substance abuse. There is a strong family history of depression in both of her father and her mother. And she's had some psychosocial stressors with financial strains at home, but she states that these have been improving. She also says that her home environment is safe and she has a good social support system. So basically what we were wondering at the close of this case, Dr. Akivni would really like to explore better ways to wean patients off of SNRIs, and we were kind of unsure if in this situation we even needed to wean or if Prestique could have been started immediately had her insurance approved it. And then our other question is how to get insurances to cover these newer medicines like Prestique. So any feedback would be great.
Great. Thank you so much, Kristen.
Thanks.
Thank you. So I'm going to ask you guys, Jennifer, I know you just came in, but Vanessa, do you have any thoughts or comments about how to do this? I know you're in PA, so it may be a little different.
I'm a nurse practitioner. I'm a nurse practitioner.
Yes.
Yes, I have several thoughts. One is that I don't know if any of you have ever attended the Psych Congress meetings, regional Psych Congress. They're very, very helpful. They offer them around the country. You could probably just Google that and you'll find where they'll be close to you. They're free. Find them very informative. When I've attended them, the psychiatrists there have said that, you know, there's like a group of people that the SSRIs, they just don't even help them. In my opinion, and this is just my opinion, that person has a lot of duplication. And then I personally think that amitriptyline is one of the obesogenic drugs, and so for people that are obese, it's not really doing them any favors. You might want to look into a sleep study for this person, and I'm just I may have just a little bit of a, I have concerns at this point. I don't know if anyone in the audience read the book Bottle of Lies. It's by I believe her name is Catherine Ebon, but it's a book about the generic drug industry, and it talks about a lot of falsifications and lack of ethical standards, and it's kind of compared to Upton Sinclair's the book The Jungle and the meat packing industry before there was a lot of FDA regulation, because we're now having drugs made overseas, and so the FDA processing and standardization and quality really just cannot, you can't have that same oversight like you have here. And so it's leading to, I think, some concerns about really the authenticity, potency, and you know, assurance that some of the generics that we're getting are really doing what they should be doing for people.
Sure. That's great. Thank you so much. I'm going to read what Dr. Goodytoon sent to us. I apologize in advance for all of the mistakes I'm going to make, but I will send you a written copy of this so it makes more sense. And I'm going to let Cassie and Amanda talk about any therapeutic things that might help this lady out. So, Dr. Goodytoons wondered if the patient got satisfactory relief off of any of the antidepressants. Did any of them help her?
So she would initially get benefit, but then like ultimately the trial would fail. Like she would be on them for like 6 months with worsening of depression, but like in the first couple weeks she would report feeling better, but then like that would wear off really quickly.
Okay. So she said if there was only minimal response, then she probably didn't. So that's funny. But she said if she did happen to do well on Cymbalta, that might have been helpful to increase to 90 milligrams. And then if she had any other negative responses to the mentioned medications. Did she have any bad responses to this?
So to venlafaxine, that was the only one that she had like a complaint with. She said that she basically was having like a lot of memory issues and a lot of cognitive issues, so she didn't like it for that reason. As far as the Cymbalta, she just said that she never felt that she had an effect from it, like it was never beneficial. So that's why we just discontinued. But maybe upping it would have made some sort of difference. I'm not sure.
Great. So then she said that she was just questioning it to make sure that it was a therapeutic dose. And she said that recurrent depression component has a suggested mood disorder, maybe possibly underlying the issue. And then that happens a lot in people with multiple failed medications that are all different like that. So there's no specific formula for tapering an SNRI or SSRI. SNRIs are notorious for having significant flu-like or worsening symptoms.
Mm-hmm.
The slow taper is best and should be adjusted according to the patient's reported side effects. Okay. She's seen it take several weeks to taper off Effexor and Cymbalta, but other SSRIs like Paxil also.
Okay.
I'm not sure going to Effexor will necessarily help, since the patient previously listed this as ineffective due to memory loss. Mm-hmm. And Pristiq, which is truly the active metabolites of Effexor, may be better and have less side effects, but it might not also because of those. says Elavil is not necessarily an issue, but if there is any issue with suicide, it has a potential for lethality and overdose.
Mm.
And then she said that she wouldn't make Ativan a PRN. If it is necessary for treatment in the prescriber's mind, she would schedule it. If there's truly that much need or only very infrequently, then it would be better to use something less problematic like Buspar or Atarax, and milligrams of either of those.
Okay.
And then she's also available for questions via phone, which I will send you.
Nice.
Thank you.
Yeah. On to the therapy.
Oh, could I add another comment about this person? Why aren't they on like a dopamine effect, like the bupropion, like the Wellbutrin, especially with the quitting smoking?
You know, I'm really not sure why that route wasn't explored. I think maybe because like worrying of like increasing her anxiety, because you know sometimes they say Wellbutrin like activating in that sort of sense. So I think maybe that's why it was avoided, but kind of unclear. And this was a patient that like came to Dr. Keaveney, and she was already on like a bunch of these medicines. Like she was on lorazepam already like when she showed up. So I think Dr. Keaveney has also been trying to like change them around and find a strategy that like works well with her without like completely like rocking the boat. So
I like a lot of the mindfulness and like the you know the diet and the exercise and some of the things that I think really are necessary for people just naturally not to feel depressed. And I don't think it's offered enough to people. I know here it is, and I say like, oh, you should do Tai Chi or go do some mindfulness or take some classes, but a lot of our population here, just the transportation is an issue, and it's just not affordable. You know, if you've got money, you could probably buy it yourself, but if you're a person of limited means, but I'm a big believer in that as helpful.
yeah,
and I kind of wonder, she's 37.
Yeah, she's
like the premenopausal stuff too. I don't know about anybody else, or I'm just going to speak as a woman myself. I felt like that did a lot to me emotionally. It's kind of like a harder, was for me anyway. It was emotionally kind of.
Great, thank you.
Well, one of the things that kind of stood out to me is that I heard, you know, she has anxiety, but you know, do we know if it's PTSD, generalized anxiety, panic disorder, OCD? I mean, some of it, I'm not sure how much it necessarily would affect the medication she's given, but there are certain first-line treatments for things like OCD, you know? So I think having a more clear diagnostic picture might also help to guide some of the medications. And I mean, we know she's tried some of these things, but I don't know if you have a sense of, you know, however many times you met with her, if we could actually know a little bit more specifics about what this anxiety actually is.
Yeah, for sure. And I've only on 2 occasions, and she didn't feel comfortable enough talking about mood stuff in front of me. We talked more about like, one time she came in for sinus drainage, and the other time was for like an upset stomach. So we would talk about those issues, and I would kind of like broach into mood, and she would tell me a little bit about her mood, but she would want to talk more to Dr. Keaveney. So I would excuse myself from the room so as not to make her feel uncomfortable in that relationship that they had already had. But yeah, so I'll have to talk to Dr. Keaveney and see how she would better like classify her anxiety symptoms, whether it be more OCD or more of a PTSD kind of picture.
Yeah, or is it even just, you know, a generalized anxiety, or is it, you know, I think maybe that would help a little bit more to sort of guide her, even her treatment or therapy, you know?
Yeah, for sure.
And she's actively involved in therapy now?
She just started counseling. Before, she was kind of apprehensive about it. She just would have rather taken medicine and not had to go see anybody. But everything that's been going on with the duloxetine and the worsening of her anxiety, it really like came to a point where she was like, yeah, I'm going to go seek counseling. So right now she's set up with FMRS and she's been seeing them. And we're trying to get her in with a psychiatrist locally because transportation's a little bit of an issue for her and she doesn't want to have to travel somewhere far to see a psychiatrist. So.
I'll send it to you in the recap, and Jen may also have, Jen's down in your area. She may have suggestions as well. But I do know of a grant-funded transportation service right now that can help you get to the, or can help people get to the appointments, not you specifically, but I'll send you that. It's like a map and they have the phone number to call and what region and stuff. So I'll send that to you with that.
What is that grant?
I will send it to everybody.
Okay.
It's just, they can do it on the spot. Like if you call and say, hey, I'm running late for an appointment, they'll come and pick you up. It's like Mountain Line's doing it around here and a couple of other ones, but then all across the state, there are different transportation services like going out of their way to pick up somebody. And they can also schedule the appointment too. If it's a scheduled appointment and it's somebody who doesn't have transportation, they'll make a point to go get them. Yeah.
Just out of curiosity, it says she has obesity. Do you know how severe is her obesity?
It's like her BMI is 32.
Oh,
so
like
stage 1.
Does she have other medical comorbidities or?
She does have diabetes and she does have hypothyroidism, but both seem to be pretty under control at this point in time. Like her blood sugars have been ranging between 100 and 120. And then her TSH, all of her recent like thyroid labs have been within normal limits.
Okay.
She's on Synthroid, I think, currently.
So it seems like she's pretty adherent to like her medical regimens and tests her blood sugars and things like that.
Yeah, for sure.
That's good.
All right. Thank you so much, Kristen. I'll send you all of this stuff written up so you don't have to write anything down, but you can send it back to the physician you were working with.
Sounds good. Thank you all for your input.
Yeah. Any other questions or anything about this or about any other things that have come up for everybody?
That person has diabetes.
Mm-hmm.
There's a high correlation with diabetes and depression. They haven't proven that it's the high sugar levels, but I heard a neurologist say that the way that the brain feels pain is depression. And so, you know, the diabetes is an inflammatory condition and it's tough. Also, I heard something else that was more about the opioid epidemic, but it just said that, and I think that this was someone's opinion, but with all the, especially like in the Northeast, with all the jobs that used to be like plentiful and good and well-paying and everything kind of just declining in those areas, that leaves people without a certain amount of identity and just power because they're economically in just an economically hardship area, and a lot of people have, you know, a lot of the population have left a lot of these areas. And I think that there's something about that too, you know, community and support and self-identity and, you know, good paying job.
Yeah, definitely.
It's like a lot of moving parts.
Yeah, I mean, I agree with you. She has a lot going on, and it's kind of why I was wondering too, like her level of obesity and the other comorbidities, because that is true. There's definitely a high correlation between depression, diabetes. I don't know how long she's also had diabetes for. I mean, just even managing a chronic illness like that can be very stressful, very overwhelming, having to deal with that on a day-to-day basis. And depending on your level of support, I mean, that's a lot in and of itself to manage, and then you add all these other stressors on top of it. So, and then even just with I know she said she thought one of the medications was contributing to like memory, but like cognitive sort of fogginess and stuff. She didn't use that word, but memory problems. But you can get that actually with, diabetes and obesity. And there's been a lot of studies that show that just you can have actually cognitive impairment with that in and of itself, with obesity and diabetes and kind of studies showing that that's more with severe obesity before and after bariatric surgery and things like that. But yeah, so there's a lot going on with this person. So I think we just have to kind of keep in mind her whole sort of medical picture, both physically and psychosocially, what's happening with her. Yeah.
Excellent. Thank you again, everybody, and thank you, Kristen.
Thank you.
So I'm going to turn the time over to Cassie. She's going to talk to us about some holiday eating, counseling, strategy things. So I can't ever find what mouse is right. I have all of the handouts.
I said, yeah, I didn't. Oh, if you want, I think. Did you send some of them yet or no?
I haven't sent them.
Okay.
I will send them.
I think some of these documents I may have sent before, but they're kind of relevant. So I don't have like a PowerPoint necessarily, but some of these documents could be helpful just in working with people when you see them one-on-one, and in terms of like helping them set goals and kind of work through, especially helping them with managing their weight, tracking calories, managing weight, helping them set goals around eating, exercise, even, managing blood sugar, things like that. Everything we've kind of talked about today. I was telling Caitlin earlier, actually, so for those of you who don't know, so I work actually primarily with a bariatric surgery team here at WVU. So I work with patients both pre and post surgery who are going through that process, but then also working with people, that are trying to make changes to their diet, their exercise, anything to kind of try to make a healthy change. And sometimes with those surgeries, you have to actually lose weight prior to surgery due to insurance requirements, or the surgeon may want you to lose weight and things like that. But then I've also, worked with people kind of non-surgically who are looking for different ways to try to lose weight, maintain healthy lifestyles and things like that. So different interventions to help them as well. So I'd be happy to do a whole other talk just on bariatric surgery, because that's a whole, I could talk forever about that, because that's what I do every day. But just for essence of, we don't have a whole lot of time, so I can just kind of keep this focused on just sort of helping patients sort of set goals. And then with the holidays, it's always a struggle sometimes for people who want to actually, either lose weight or maintain weight or try to just stay healthy during this time of year. And it's really challenging when there's like food everywhere. So, kind of what's the best advice or suggestions or tips that you can give to people or work with people on? And I think, maybe the first thing I can show you, and I have a slide on this too, is I like to kind of focus on can you pull the weight control registry one? Is I like to actually highlight, I show this and I talk with patients about this. I don't know if anyone's ever knows about this. So the National Weight Control Registry data, this is data on actually over 4,000 adults who lost about 30 pounds and maintained their weight loss for about 1 year or more. So they've continued to actually follow all of these adults out, and they asked them, what really helped you be successful? And they found that almost all, like close to 90% of these people actually, not to any surprise, use both diet or nutrition and physical activity to help them lose weight and maintain their weight loss. And most of these people ate breakfast. And I find that when I work with people, and I'm sure, you know, in working with patients, you've encountered this too, is that a lot of people have this mindset that they skip meals, and they think that somehow skipping meals is going to help them lose weight. And it's just the opposite, right? I mean, I'm talking to people who know this, right? It's the whole idea of like breaking the fast. Like, you actually have to eat consistent meals, and you have to, you know, eat your 3 meals and 1 to 2 snacks a day. And you have to do this regular, consistent, normal schedule eating pattern in order to lose weight. And that's what the data will actually show. And so, you know, part of it is like getting people to buy into this idea, and the research data to show that this is actually what you need to do to boost your metabolism and lose weight. So that's part of it. So 75% of these people actually self-monitor or weigh themselves at least once a week. So that, again, to kind of keep track of how they're doing. So they use that as a way to monitor what you know they're doing. Most of these people are actually still tracking their calories. So they're writing things down, whether they actually write it down. A lot of people these days use like apps like MyFitnessPal. There's a lot of different apps. That's one in particular that people like, because they can actually take like food labels and scan them, so they don't have to continue to write things in all the time. But that can be really helpful. Most of these people are actually getting more than the recommended physical activity recommendations that are proposed by the Surgeon General. So these people are really active, and almost half of them use walking and an additional form of exercise. So, you know, people actually, walking is a pretty common way that people lose weight and maintain weight. But a lot of times they're also doing something else like strength training or something of that nature. I mean, I know we have the issue in our state of resources and lack of resources. So it's always an additional challenge sometimes to kind of think about or help people come up with other ways they can do activity and be creative around that. So sometimes that's our job, to kind of help them think about other things they can do. But you know, walking is one thing they can do, and just kind of helping them come up with something around that. The other thing is that for these people that have maintained this weight, they also kept this pattern up even on the weekdays and the weekends. So they really tried to maintain what they were doing on Saturdays and Sundays too. So I think, you know, sometimes people want to know, well, what helps them be successful? So the holidays can be a kind of a nutty time where people's schedules are all over the place. So consistency is helpful. Consistency is key. Another thing I like to tell people is, look, you know, don't be too hard on yourself. Maybe the goal is you just want to try to maintain your weight through the holidays. Don't try to lose weight during the holidays, because most people actually gain I think the average weight gain is about 8 to 9 pounds from Halloween to New Year's, believe it or not. It's actually quite high. So you would be successful if you could just try to maintain your weight. So maybe it's not a realistic goal for you to think that you're going to lose weight. Maybe you want to just actually try to maintain your weight. So why don't we just try to table your weight loss during these holiday months and just strive for maintenance? So I actually kind of steer people away from setting themselves up from being unrealistic about things. So does anybody have any thoughts? I'll stop here before I say anything else.
This is Jennifer. I had to join late, so sorry I didn't hear the case, although it sounded really interesting. I love that slide. I would love to have a copy of that to put in the room. That's so interesting. I think if people could just see this is what works for people, that might be really helpful. And I do the same thing with people about telling them to just try to have their goal be maintaining. I say the average person gains 5 pounds. So if you stay the same, you've actually lost 5 pounds. Is what I tell them. But anyway, that was helpful. My one question I have relates to, and I don't know if there's data about this, but it's just been my observation for many years that people's depression worsens over the holidays too, not just challenges with eating, but challenges with mood. And I don't know if you have any ideas or suggestions on that. I try to ask people how they feel about the holidays before I presume that it's going to be hard, because some people love the holidays. But whether it's the holidays or this time of year, I in my practice, so that's anecdotal, but I know I tend to see more people with suicidal thoughts around this time of year and stuff like that. So I wondered if you had any thoughts about that.
You know, that's, Amanda might have some thoughts on this too, but I mean, that's a good point. I mean, the holidays you're right. Some people, it can be really happy, and other times for people that it brings back memories of people that they've lost, that that their family isn't close, or they don't have people to spend with, or they're alone. And so it can be really tough, And so I think ultimately it's like, if you're working with these people and you know that this is coming up, and you know that this potentially, the person that you're working with, you can maybe have a conversation and start to think about, okay, what can I do to support you during this time? Or can we come up with a plan for what do you plan to do, on the holidays? Or is there someone that you're going to be with? Or, what can we do? Basically, it's almost like, a lot of times they're going to have a safety plan or things like that anyway. So you can have some of those things in place. But you're right. I mean, I think other than just the normal things you would do to have safety plans and things in place for them, and just, I think opening up the dialogue with them is important, to say that, like it's not necessarily the best time for everybody, and how is that going to be for you, and how are you going to make the best of it kind of situation. I think sometimes even just talking about it can be helpful in that way. Do you have any thoughts about
I think
that?
I think especially around the holidays, I think one of the pieces that I actually do is, because I don't do a whole lot of nutrition work, but I will say that around the holidays I do, because you're right, a lot of people become suicidal around the holidays, and many of the patients that I work with and the families that I work with, a lot of them are reminded of the lack of support and the lack of family that they have, and so that really increases some of that suicidal ideation and depression, mood. So we always talk about nutrition, because that has a huge impact, especially with the change in the timing, the weather. I have a lot of families that naturally start to crave more sugars and gluten around this time, and that totally impacts your mood. I have one patient who is chronically suicidal, and it usually increases during the holidays. But one thing she just identified was how gluten impacts her mood significantly. And so she's eliminated all gluten from her diet. And this has been the best time since she's done that. So it's pretty amazing how they're linked.
That's interesting. Thank you, Bob.
Yeah, I think it's pretty on point of you to just kind of recognize that and bring it up with your patients, especially if it's a concern. I think that goes a long way with them, and just they feel understood when you can say, okay, let's talk about that, and let's come up with a plan, so you feel supported during this time. So I do have this in a handout, so we'll send it to you if you want to.
I would love that. Thank you. That's just I really like that. I think I had heard about that before and forgotten. I think I actually read it in just the lay press, some newspaper. I think it's really good to show people those pointers.
Yeah, like I said, I mean, so there's some other handouts too. So like, I mean, for essence of time. So sometimes it's just, like I said, I think I've sent some of these before, but I'm sending them again. So like, there's, depending on how much time, you spend with people, there's sometimes I think actually, which can be really helpful, is that when people are actually trying to make healthy choices, a lot of times people have a hard time sort of being assertive or just saying like, oh, I can't, like they have a hard time just like saying that they don't saying no to people, because that's how a lot of people show their love is through food, right? And so sometimes it's just actually walking through scenarios with people. So this is like a sheet. I actually took this sheet from a protocol that I did a long time ago on like a weight loss intervention. But so kind of like sometimes it's a role play and just, okay, how would you handle this if you were at a party and you were offered this food and you didn't
Help
want
yourself. They're right in there.
So because people have a hard time saying no because they don't want to disappoint people. They feel like they're at someone's house, they want to accept it, and so I think sometimes you can do a lot of good work around letting people know that they're allowed to say no, and it doesn't mean that it doesn't mean anything bad. And so sometimes you can do a lot of good work just in assertiveness skills actually with people and giving them permission to say no. Because that can be really difficult for people because because the alternative is they may actually eat something that they don't really want, and then what happens is they get in this cycle where they feel guilty because they ate it, and then it sets up this whole pattern where, you see what I'm saying? So that's kind of the scenarios for special events. So kind of helping people with that. And then the other one is just kind of a form that allows people to actually list different foods and challenges that could potentially come up. I mean, this could be sort of like, this is more therapy, if you will. Like you could kind of give somebody this as a homework assignment, like if somebody was actually coming to you for sort of weight loss or weight management, and you could sort of discuss this, if you will, like as homework, so they could come up with strategies to handle this, and then it gives them a chance to sort of at the bottom, to just come up with an action plan for how they would handle the situation. So it again sort of gives them an opportunity to come up with a different way to handle it. So I just included those so you could have them if anybody wanted to use them. And then the other things are just sort of like go through, which I know everybody's familiar with, but just sort of motivational interviewing stages of change model. I mean, it has it going down as technically we all know it's like a spiral stage of change, but it just sort of has it this way on this sheet. But how people make a change, and then tips for the action plans. And then I have the SMART goal sheet that you can actually give out to patients. And I think if you only have, can you pull up so you can like take that, you can even, if you want to give that to patients or use that for yourself too, that's fine. That's what it's there for. The SMART goal sheet. This can be like actually really helpful if you just have like a brief visit with patients to go through SMART goals, because I think this is honestly where most patients get into a lot of trouble. It's kind of just what I was saying too, like the whole thing about like, don't try to lose weight during the holidays. Just try to maintain your weight, because it's not really realistic to lose weight during the holidays, I don't think, for anybody. So the SMART goals takes you through, like, how do you set a goal? So most patients get into this, or all of us do, honestly, get into this habit where we just say, oh, I want to exercise more. Well, what does that mean? Like, how do you really measure that? So what you really want to do is say, well, I'm going to exercise 2 days a week for 30 minutes, with my friend, because like you can actually measure that. So this kind of breaks it down and gives people examples of what that looks like. So you can spend some time and go through with them and explain, like, okay, this is how you make your goal SMART. And then if you, it's on the back, is there a back? Yeah. So then this gives them a chance to actually write a goal, and then they can check, okay, does it fit the box? Does it meet the criteria for a SMART goal? Is it specific? Is it measurable? Is it action oriented? Am I saying what I'm doing versus not what I'm not doing? Is it realistic? Like, because somebody that says, oh, somebody that never exercises, if they say, I'm going to exercise every day this week. Okay, well, that's not really realistic, right? I mean, that's not realistic for anybody. So, but saying, oh, I'm going to exercise once or twice this week, that would probably be more realistic. So, and time. So you want to put a time limit on it. Maybe I'll start with, okay, I'll do this in the first month. And then you revise your goals and go forward. So this is just a really good way a tool to give to them. And then it's nice because if you're actually, you could do this with anything. You could do this with eating. You could do this with exercise. You could do this with tracking and monitoring your blood sugar. You could do this with sleeping. You pick whatever health behavior you want, and they could do this. So whatever like they want to work on. I mean, I think it's helpful to ask them. I mean, as their provider, right? I mean, you might have something you think they should be working on, but it's probably more helpful to say, what do you think? What would you like to focus on? What do you want to work on? And then, like, let's see what they think, because honestly, a lot of these things are related, as you know, right? And smoking, eating, they all kind of fit together after a while. So if you're sleep deprived, you're gonna maybe not choose the best food, and then you're not gonna probably exercise because you're too tired. You see what I'm saying? So, giving them a chance to sort of make a choice, and then see if they, if maybe you have leverage to then say, what do you think about working, would you want to work on this as well? But those are just some things to maybe think about, and that could be useful at some of your visits, either whether it's like therapy or just like a brief visit with them. So hopefully that's helpful.
That was great. I really like a lot of these, but a lot of them you can stick on like a patient's refrigerator or something. And
Oh,
just
sure.
Look at it and remind themselves. I'll be sending all of these out after the session. Does anybody have any questions or anything else you guys want to bring up? That was great. Thank you so much.
Sure.
I know we had a lot of, yes, absolutely.
I find that I get a lot of people that are just coming in crisis to crisis, and it's really hard to for them to focus on health, and for us to focus on health, and to really make that, even though it's important. I also think personally that our culture just isn't designed for us to just get the type of exercise that we could, should, and do need. I don't know if anyone's ever read the book. I don't mean to keep referencing books, but I have found this book extremely helpful for myself. The Finnish Way. So like in Finland, it's about this lady that's from Canada, but of Finnish descent, and she moves back there, and she finds that with that lifestyle of biking every place, eating lean protein and, not a lot of sugar, what the one commentator said about the sugar, I think there's a huge connection there. with people's moods. But anyhow, she really, like, her depression lifted, and certainly, you know, there's a lot about community and certain other things that she talks about in the book that's very helpful. But I don't know about there in West Virginia, but I imagine it's similar to here in Pennsylvania, that if you don't have a car, you're really not getting anywhere if you live, like, not in town. And even in town, sometimes it's tough.
This is very true.
Yeah. We'll check on that. The Finnish way? Is that what you
Yeah. And then the other book I mentioned it's called A Bottle of Lies.
Yeah.
And that's about the generic drug industry.
Perfect. Thank you so much. That's great. All right, guys. So we are good for today. Our next session is actually right after the holiday break. So if you guys have any cases and want to get those turned in, Mitra and I are accepting them immediately, because we know it's going to be super hard for people over Thanksgiving to be like, yeah, let's talk about this guy. So the next session, I think, falls on December 4th, anything, 5th, sometime. We'll remind you. We'll send it.
Oh, it is the 4th, you're right.
Oh, it's the 4th. Okay, but everybody have a wonderful Thanksgiving holiday.
Thanks.
Have a great day. Thanks.
Thanksgiving. Bye.